I think one of the challenges for all of us is that we have to be concise and try not to make a file too big so that it actually can hold on Blackboard and be uploaded. My name is Peter Keast, and I just wanted to discuss some patient preferences and barriers to evidence-based practice. I'm going to use my grandmother. Unfortunately, she's passed away, but that is not immediately relevant. She was a human being who was very tenacious, very stubborn, and very wonderful. She died at 93 years of age. So my clinical background is medicine. I've always done medicine, very little surgery, but there was a time when I was doing a master's degree that I had to write a thesis on something, and it was evidence-based practice related to risk stratification for the elderly for atrial fibrillation. And the long and short of it, atrial fibrillation is underdiagnosed. If you're not diagnosed and you go on to have a stroke, the stroke resulting from AFib is worse than any other kind of stroke, with the exception of bleeding and trauma. The disability scores are higher and the outcomes for recovery are poor. And so there was a time in which the CHADS, and then the CHADS-2, and then the CHADS-2 VASC, in which people were researching risk factors that predisposed usually elderly persons to stroke risk from atrial fibrillation, and that's why those clinical tools were invented. And I learned in my research that there was a antagonist score called the has bled, or the hemorrhages score, and that speaks to the risk factors related to bleeding outcomes for people who are receiving oral anticoagulation. So my grandmother came to me and she says, my cardiologist wants me to go onto a blood thinning medication. My cardiologist says that I have atrial fibrillation and that I need anticoagulants. I said, that is generally correct. And she said to me, okay, well, which one should I take? I said, that's between you and your doctor. That's not something that I can advise on. You're not my patient. Anyway, I was yawning, trying to keep it in. She decided to pursue oral anticoagulation, and I just said to her, I said, just tell your doctor to discuss with you openly the risks of bleeding if you're on such a pill. She did, and I actually think in doing her scores in 2020, that her bleeding risk score compared to her thromboembolic risk was greater. And so she was more likely to have a bleeding event, not to mention that she had had 3 previous falls. And so despite the many nuances of her healthcare, she talked to her provider and said, actually, you're right. Surely you've had a bunch of falls, and if you smack your head, that could be a big deal. She decided to go with the anticoagulation. And actually, I think that it's fair to say that the evidence was hung. It was like a hung jury, but as well, the evidence was strongly suggestive that her bleeding risk was significant. And I don't think that she appreciated that. So back and forth, she ended up on an oral anticoagulant, and she did okay. Sorry, I know you want a sad story. She did fine. There was a time after many falls later and some cognitive decline that we stopped it. And what happened was she had a large embolic stroke within the week of that anticoagulant medication stopping, and it led to her demise. Moral of the tale, these evidence-based things are very challenging to get into real-life situations. It's a risk, no matter what evidence you bring forth. I learned in that thesis project that there was always another side, the opposite side to what you're recommending, because if someone has heart failure and you want to start them on Lasix, that's a good idea, except when it's not. If somebody has high blood pressure and you start them on metoprolol, that's a great idea until it's not. Nothing that we do is without risk. And for me, learning how to mitigate certain risks based on, like, for instance, risk scores was extremely helpful. How would you navigate such a situation? Well, it was bloody hard. I tell you what, I think I had 3 or 4 phone calls between my dad and the cardiologist and my grandmother, just trying to build bridges and work with the evidence as myself and the cardiologist saw. My cardiologist was very, very helpful, and I wouldn't speak ill of him at all. He did a great job. But I think the strategy that I would propose to overcome them is just that. It's a conversation. It's an open conversation, a dialogue, without agenda, without power involved, without any sort of orders to follow or send, just to be like, okay, patient, family, well-meaning grandson and provider, and then agreeing on the risks that we're going to accept as a team, because healthcare is a team sport. It's not an individual sport. Thanks, guys.